Good morning. My name is Koerner. I work at OHSU in Portland, Oregon. It's my great pleasure to talk to you today about recent advances in monitoring for neurocritical care patients. Why do we monitor? We'll all agree that prevention of secondary brain injury is a key goal of neurocritical care. Mass effect, ICP elevation, inflammation, disruption of the blood-brain barrier, dysfunctional autoregulation, and reduction of cerebral blood flow can all drive injury. They lead to regional or global ischemia and tissue hypoxia and subsequently cause cell death. The patients that are at highest risk for the secondary brain injury are the most severely injured that give us a limited clinical exam to follow. And thus, objective monitoring techniques for cerebral physiology and function are critical to achieve our goals of anticipating and predicting deterioration, recognizing any abnormalities early, supporting goal-directed interventions, and confirming the effectiveness of our treatment. Ideally, monitoring would also support prognostication. I will discuss several core parameters that can currently be monitored: intracranial pressure and cerebral perfusion pressure. We'll talk about ICP goals and management with and without an ICP monitor. Cerebral autoregulation, specifically the pressure reactivity index and the optimal CPP. And finally, tissue oxygenation. We know that ICP elevation associates with mortality and poor functional outcome, and that has been shown in multiple studies, including this recent investigation of patients with hypoxic ischemic brain injury, in which elevated ICP associated with poor outcome. Interestingly, the study also measured pressure reactivity index and brain tissue oxygenation monitoring techniques that I'll come back to later in this talk. This elegant, very recent multinational observational cohort study, the SNPS ICU study, investigated the use of intracranial pressure monitoring in real-life conditions. And they found that there was significant variation in the use of ICP monitoring between institutions and between countries. They did confirm that the use of ICP monitoring in the most severely ill patients, specifically those with a unilateral unresponsive pupil, associates with reduced mortality. Also, ICP monitoring associates with increased therapeutic intensity, likely not surprising. What is an appropriate intracranial pressure to target? A very large recent observational study captured ICP values in over 500 neurocritical care patients. And they suggest that a normal ICP may be about 8 or 9 millimeters of mercury. As you'll see, the red arrow points to the ICP number that was present most commonly in this patient population, and it was about 8 or 9. The study also confirmed that elevated ICP associates with poor outcome. In this particular study, the cutoff value was an ICP of higher than 19 millimeters of mercury. As you know, there's some controversy about the use of intracranial pressure monitoring in TBI patients, caused by the randomized controlled trial, the BEST TRIP, that was performed in Latin America and published in 2012, that failed to show a mortality benefit in patients that were monitored with ICP monitoring. Nevertheless, the most current iteration of the Brain Trauma Foundation recommendation still recommends routine use of ICP monitoring in TBI, specifically for patients who have a GCS score of 8 or less and have CT evidence of ICP elevation. The ICP level to be targeted per the Brain Trauma Foundation is less than 22 millimeters of mercury, which you'll notice is slightly higher than the numbers that I just showed you. It is recognized that these are Class 2B recommendations, thus based on low quality of evidence. Recognizing that there are many places that do not routinely use intracranial pressure monitoring, there was a recent Delphi consensus statement to suggest treatment guidelines for these patients. The treatment recommendations are the same that we're all familiar with from the Brain Trauma Foundation, but they are recommended to be used based on CT monitoring that is repeated every 24 hours and on worsening of neuro exams, specifically new motor deficits and pupillary changes. You'll remember that when intracranial compliance is limited, small volume changes can affect intracranial pressure, as is illustrated in the red bar on this graph. When autoregulation is altered, blood pressure changes can affect blood volume. And so we can measure or calculate a cerebral vascular pressure reactivity index that is a moving 5-minute correlation coefficient between the average arterial blood pressure and the ICP. If this pressure reactivity index is positive, suggesting that as blood pressure increases, so does ICP, that suggests poor autoregulation and also poor intracranial compliance. We've learned that the pressure reactivity index correlates with outcome both after TBI and hypoxic ischemic brain injury. We also know that a cerebral perfusion pressure of 60 to 70 millimeters of mercury associates with good outcome in TBI, and that the extremes of CPP, both very high and very low CPP, can affect autoregulation. The pressure reactivity index can now be used to titrate optimal CPP, as is illustrated in this graph that shows a U-shaped curve when pressure reactivity index is graphed against CPP. The point in the curve where pressure reactivity index is at its lowest, meaning autoregulation is the least compromised, is defined as the optimal CPP. We've recently seen that after TBI, any time that is spent at a CPP that is less than the optimal CPP assessed by these measurements correlates with mortality. However, this is quite different in subarachnoid hemorrhage, where in a large retrospective trial, both MAP and high CPP in the late vasospasm phase correlate with improved outcome, but the delta CPP, so the deviation from the optimal CPP, was not a predictor of outcome. To investigate this further, there is a current randomized clinical trial ongoing in TBI patients, the COGITATE study, that compares traditional management targeting a CPP of 60 to 70 millimeters of mercury with treatment based on CPP optimal. Again, this study is currently ongoing. In the meantime, we have a recent Delphi consensus study suggesting CPP targets in patients with TBI. The recommendations were that CPP should be individualized, that low CPP is more dangerous than high CPP, that more research is needed to validate individualized and dynamic CPP targets, and that currently we cannot recommend any specific methods of assessing cerebral autoregulation. Moving on to brain tissue oxygenation, typically measured by fiber optic probe. Brain tissue hypoxia does not predict outcome in high-grade subarachnoid hemorrhage patients. And that is true even though targeted management can actually reduce the time of brain tissue hypoxia. Similarly, brain tissue oxygenation does not correlate with outcome after hypoxic ischemic brain injury. On the flip side, you'll all remember the BOOST-2 randomized control trial that showed that in patients with TBI, a management strategy that was aimed at optimizing brain tissue oxygenation was able to reduce brain tissue hypoxia and always also show a trend toward lower mortality. The follow-up larger trial, BOOST-3, is currently still ongoing. Probe location is critically important for optimal measurement of brain tissue oxygenation. In this observational trial of patients with large intracranial hematoma, status post-evacuation, brain tissue hypoxia predicted poor outcome, but only when the probe was positioned within a centimeter of the lesion and not when the probe was positioned in normal tissue. So to summarize, there is currently no single measurement that can optimize outcome. At the current point, comprehensive care that incorporates clinical experience and multiple data points may thus be best. Pressure reactivity index, optimal CPP, and brain tissue oxygenation hold the most promise in patients with TBI. And we definitely need more pragmatic trials to test real-life relevance of monitoring strategies and the associated management. I thank you for your attention and look forward to the discussion.